Hi, I'm Ryan, and today I'll be presenting about borderline personality disorder, or in short, BPD. This complex mental health condition is often stigmatized or misunderstood, where in fact it requires compassion and understanding, as those diagnosed suffer from deep emotional pain and instability. I will speak today about the background and history of the disorder and how we know the term BPD today, the diagnostic criteria in the DSM 5. However, it did start in the DSM 3 in 1980. The types of treatment, comorbid mental health illnesses, and underlying medical illnesses that can have traits of BPD as well. The history of borderline personality disorder starts with patients that could not fit into the category of psychosis, which is when an individual loses touch with reality, seeing and hearing things that are not there, and patients that weren't fitting into the category of neurosis, involving symptoms of stress, anxiety, and depression. As the patients didn't fit into these two categories completely, they fell on the border, presented by Out of Stern proposing the term borderline personality in 1938. Borderline Personality Organization was introduced by Otto Kernberg in 1975. This response referred to patients having consistent patterns of instability and a disturbed psychological self-organization, which is difficulty in regulating emotions, problems with relationships leading to emotional numbness, a negative self-concept, low self-worth, and intense anger. Finally, in 1978, John Gunderson and John Kolb, whom I couldn't get a photo of, had incorporated a range of symptoms, and the term borderline personality disorder was created. The symptoms included fluctuations of confidence to absolute despair, unstable self-image, rapid changes in mood with fears of abandonment and rejection, suicidal thoughts, self-harm, and transient psychotic symptoms, including hallucinations and brief delusions. However, those with BPD who suffered from psychotic hallucinations these did not occur long enough to fit into the category of psychosis. 1.8% of the global population, or approximately 144 million people, have been diagnosed with borderline personality disorder. In prisons, the global percentage of those diagnosed is between 9 and 30%. Here in Australia, 2 to 5% of the population that has been diagnosed is between 520,000 and 1,300,000 Australians. Women are more likely to be diagnosed than men. BPD can and is often diagnosed with comorbid mental health illnesses. In fact, it is uncommon to see someone who is diagnosed with BPD individually. Comorbidity occurs in general with anxiety, depression, PTSD, eating disorders, substance misuse, and bipolar. As previously stated, people with BPD can have, in extreme cases, visual and auditory hallucinations. They are brief but are linked to severe emotional instability rather than psychosis itself. Because of considerable overlap with other mental health disorders, many have suggested that borderline personality disorder should not be classified as a personality disorder. Rather, it should be classified with the mood disorders or with disorders of identity. Its association with past trauma and the manifest similarities with PTSD have led some to suggest that borderline personality disorder should be regarded as a form of delayed PTSD. The DSM-5 BPD diagnostic criteria states that someone with BPD must have a pervasive pattern of instability of interpersonal relationships, self-image, and affects, and marked impulsivity beginning by early adulthood and present in a variety of contexts as indicated by 5 or more of the following: frantic efforts to avoid real or imagined abandonment, a pattern of unstable and intense interpersonal relationships characterized by alternating between extremes of idealization and devaluation, identity disturbance, markedly and persistently unstable self-image or sense of self, impulsivity, and at least two areas that include spending, sex, substance abuse, reckless driving, or even binge eating, recurrent suicidal behavior gestures or threats of self-harm, affective instability due to a marked reactivity of mood, such as intense episodic dysphoria, irritability, or anxiety, usually lasting a few hours and rarely more than a few days, chronic feelings of emptiness, inappropriate intense anger or difficulty controlling anger, such as frequent displays of temper, constant anger, or recurrent physical fights. Transient stress-related paranoid ideation or severe dissociative symptoms are also one of the 5 or more following criteria to diagnose someone with BPD. BPD causes are complex and remain uncertain. No current model has been advanced that is able to integrate all of the available evidence. The following may be contributing factors, such as genetics and constitutional vulnerabilities, neurophysiological and neurobiological dysfunctions of emotional regulation and stress, psychosocial histories of childhood maltreatment and abuse, and disorganization of aspects of the affiliated behavioral system, most particularly the attachment system. Twin studies suggest it is likely that traits related to impulsive aggression and mood dysregulation, rather than borderline personality disorder itself, and are more so transmitted in families, thus suggesting BPD is not heritable, but traits of it are. For neurotransmitters, these have been implicated in the regulation of impulses, aggression, and affect. Serotonin has been the most extensively studied of these, and it has been shown that there is an inverse relationship between serotonin levels and levels of aggression. Reduced serotonergic activity may inhibit a person's ability to modulate or control destructive urges, although the causal pathway remains unclear. Reduced 5-HT or 1A receptors mediated responses in women with borderline personality disorder and a history of prolonged child abuse have been noted, suggesting the possibility that environmental factors may mediate the link between the neurotransmitter 5-HT and aggression. People diagnosed with borderline personality disorder also normally have a history of physical, sexual, or emotional abuse. It is reported that 84% of people with BPD had described experiences of neglect and emotional abuse before the age of 18 by their mothers and fathers, with emotional denial of their experiences by their caregivers as a predictor of borderline personality disorder. The vulnerability that is induced from stressful psychosocial experiences likely to be associated with failure in families such as neglect, rejection, excessive control, unsupportive relationships, incoherence, and confusion likely makes them with disorganized attachment. This neglect stems to the fears of abandonment, as BPD is strongly associated with insecure attachment styles. BPD and other medical conditions must be distinguished, BPD must be distinguished from personality traits arising from other medical conditions. Conditions associated with personality changes including head trauma, cerebrovascular accidents, CNS neoplasm, epilepsy, neurosyphilis, multiple sclerosis, endocrine disorders, heavy metal poisoning, and HIV-associated neurocognitive disorders. In other words, some medical issues can cause changes in personality or behavior that might look like BPD, but they actually have a biological or neurological origin. This occurs because conditions such as multiple sclerosis can affect the brain in ways that cause mood disorders, cognitive changes, and shifts in personality, whilst damage to specific brain regions like the frontal lobe can cause mood swings, impulsivity, aggression, or emotional instability, traits that mimic BPD. The course of borderline personality disorder is very variable in someone who is diagnosed. Most people show symptoms in late adolescence or early adult life, although some may not come to the attention of psychological or psychiatric services until much later. The outcome, at least in those who have received treatment or formal assessment, is much better than it was originally thought. with at least 50% of people improving sufficiently to not meet the criteria for borderline personality disorder 5 to 10 years after their diagnosis. Although prognosis is generally good, it is important to note that a minority of people have persistent symptoms until late in life. Recurrent self-harm may occasionally be a problem in the elderly, and the possibility that this may be because of borderline personality disorder should be considered in such circumstances. However, the prevalence of the condition in the elderly is much lower than in the young. Living with BPD is considered to be one of the most painful mental health illnesses. This is because you are living with heightened emotions that are on overdrive. An example is that someone with BPD can be in a relationship and in love with someone, but a delayed text back to them can be a trigger for the feelings of abandonment, which they can then punish their significant other to extremes and go in a spiral of self-destructive and impulsive behaviors, such as excessive alcohol or illicit substance abuse, or even self-harm. Although they have different triggers, the self-harm is associated with a variety of different meanings, including relief from acute stress and overwhelming feelings of emptiness. As a result of self-harm frequency, this disorder, it puts them also at a higher risk of suicide. Borderline personality disorder is also one of the most stigmatized mental health illnesses. People with BPD are often labeled as manipulative, toxic, or difficult. Even within the mental health system, they are sometimes turned away because of the severity of their symptoms. This stigma creates a vicious cycle in people with BPD are told their pain is too much, which just only reinforces the very fear that drives their condition. They are unlovable, broken, and destined to be alone. However, with further education and an empathic approach, this can further reduce the impact of stigma to those diagnosed with BPD across sectors of their families, the mental health practitioners and systems, and the medical system. Psychotherapy is the first line of treatment for someone diagnosed with BPD. However, positive results also occur when combined with pharmacotherapies, especially those diagnosed with other mental health conditions. Psychotherapy can improve psychosocial functions, reduce BPD symptoms, and the severity of them, including self-harm behaviors and depression. Cognitive behavior therapy is aimed at helping those with BPD able to identify and change patterns of thinking and their behavior. It focuses on their thoughts, feelings which can then help reduce their erratic behaviors, and develop coping mechanisms so that they can have a more fulfilling life. Dialectical behavior therapy is also used for BPD patients. It is highly structured psychotherapy that combines mindfulness and interpersonal and emotional regulation skills. It is designed to enable a patient to tolerate their feelings of distress by building skills of emotional regulation and interpersonal behaviors. These can include practicing calming thoughts whilst in a distressing moment, breathing techniques, palm squeezing and releasing, and practicing thoughts of their surroundings, such as 5 aspects of what they can see, hear, and feel to help create some balance. There is no evidence that pharmacotherapy is efficient for BPD core symptoms. That's why their first line is psychotherapy. Yet up to 96% of patients with BPD will receive at least one psychotropic medication, such as serotonin reuptake inhibitors, mood stabilizers, or antipsychotic medications. Pharmacotherapy is only recommended for the treatment of comorbid disorders such as severe depression or anxiety, transient psychotic symptoms, severe agitation, or aggressive behaviors. In the general population, if someone has a friend or romantic partner with BPD, they can educate themselves on the mental illness, thus so they can understand triggers, especially when talking with that person, and offer a more compassionate approach. Those who can set boundaries are more likely to have a more functional relationship as they are necessary and respectful with someone with BPD. They shouldn't take a person's BPD outburst personally, as it often isn't malice, but it comes from their fear and a deep sense of pain. Don't force but encourage therapy when needed and offer support without judgment, and be patient to those with this disorder. Overall, BPD is a significant mental health disorder. It is characterized by a person who feels emotions so deep and so painful that it stems from, in general, past environmental factors, and so therefore they have built a world that often feels unsafe and unpredictable. Better advocacy is required for those suffering from this mental health condition, and most can completely recover, as in general, this diagnosis is only temporary. However, some patients may have lifelong borderline personality disorder. Thank you for listening to my speech.